Hi, everyone. My name is Louis Shendwich. I'm a hematology and oncology fellow at Georgetown and Washington Hospital Center, and today I'm going to be presenting about ArteraAI. So this is going to be part of my monthly AI Journal Club, where we're going to be meeting every month to discuss specifically AI papers. Our goal is to build AI literacy, evaluate emerging AI applications in cancer, and also to assess the clinical validity and trustworthiness of these specific AI models. Now, evaluating an AI paper is a little bit different, but it has a similar framework to evaluating any other clinical trial paper. In clinical trials, we really look at who the patient is, what is the intervention, what is the control, as well as what is the outcome and limitations. Some people are very familiar with the PICO method to look at these specific variables. Now, in AI papers, we do something similar, but we're going to be applying the same questions a little bit differently. The first one is, what is the data and the patients that the model has been trained on? The second one is, what is the clinical decision the model is trying to inform? And the third question is how reliable and generalizable are its predictions? Now, to better answer these questions and to kind of get an overview of the specific terminology and the lexicon of artificial intelligence, we have created a primer for physicians. It's kind of an AI 101 that I'll be sending out in an email after this presentation. But in it, you can kind of go down and really look at all of the different terminologies that might be included in an AI paper. And some of the most important aspects of the AI paper are really going to be involved with appraising its domains. So kind of looking at specific areas on it, looking to see if they clearly identify what's the clinical context of the model, what's the patient population, the data input, as well as the variables, as well as clearly defining an outcome and making sure that that is something that is clinically significant. Additionally, there's new terminology such as validation and explainability that is not typical of clinical trial papers, but is very important in an artificial intelligence paper. So I highly recommend everybody to review this document as well as go over the AI appraisal decision tree, which I will have attached as well. So let's begin with today's case, which is a 67-year-old male with newly diagnosed unfavorable intermediate risk prostate cancer. The PSA is 7.4, the Gleason score is 7. With a grade group of 3 and 1 out of 12 cores that are positive. He declined surgery, and he saw the radiation oncologist who obtained an ArteraAI test. The test shows a negative ST-ADT biomarker. The patient now presents to the medical oncologist, and the question now becomes is how do you treat this patient? When you go talk to the patient, they ask a question about what is this test result? Can you trust it? And should AI be making decisions in cancer treatment? Those are all very valid questions, and some of which have already presented itself in the clinic. So the traditional answer in regards to what is the best treatment is really going through the NCCN guidelines and looking up what is the current recommended therapy and seeing the evidence through there. So this patient does have an intermediate risk prostate cancer with a grade group 3. It's unfavorable intermediate. And this risk group has actually evolved over the past 20 years and is now separating favorable intermediate and unfavorable intermediate. And the reason why I say that is because it's going to be relevant in this paper. But after you identify the risk group, you can clearly see that the recommendations as of right now, if they have a long lifespan, is to give radiation therapy with ADT 4 to 6 months. Now, the question that we will have to answer today is, does this recommendation change with this new AI biomarker? So the first question that I want to present to everybody is, what is ArteraAI? So ArteraAI is a company that uses multimodal AI tools to help personalize treatment decision in localized prostate cancer by predicting both outcomes and treatment benefits, both prognostic as well as predictive outputs. ArteraAI, specifically for the prostate, was granted de novo authorization on July 31st, 2025. It's now classified by the FDA as a Class 2 medical device, a software algorithm analyzing digital images for cancer prognosis. Now, the way that this company got to this approval was not through one specific paper. And in fact, there's at least 3 or 4 significant papers that have been released by this company. Today, we're actually talking about the foundational prognostic model, and we will also touch on the predictive model that was published 1 year later. Uh, Subsequent papers have really focused on stratifying the specific risk groups and creating their own categories similar to the NCCN, but really separating them into specific categories rather than giving them a continuous risk score. That was in 2024. And then a subsequent paper was really focusing on high risk or very high risk patients and really focusing on the prognosis of those patients included in the STAMPEDE trial. Eventually, it's quite clear that they want to have a predictive biomarker that can predict if the addition of abiraterone will help in the high-risk population. That is not what we're going to be talking about today. Today, we're talking about the foundational prognostic model as well as the predictive model specifically for intermediate risk prostate cancer. So let's start with the paper introduction. The name of the paper is Prostate Cancer Personalization via Multimodal Deep Learning on Randomized Phase 3 Clinical Trials. The goal of the paper was to build an AI model that provides accurate prognostic stratification for localized prostate cancer using biopsy images and clinical data. They had an inclusion criteria of inclusion population of 7,764 men, and the model was trained on about 5,654 patients from 5 NRG RTOG randomized phase 3 prostate cancer trials. Here's the name of the specific trials that were included. 80% of these patients were used for model training, whereas 20% of them were reserved for validation. The risk groups from the trials vary, meaning that these trials were done at various different years, and they do not separate intermediate into unfavorable or favorable, which is something that is a little bit more recent, but that was not included in these clinical trials. That's something to keep in mind. Now, all patients did receive definitive radiation therapy. The specific modality varied through each trial. And the ADT exposure also varied for each population. There was some patients who received short-term, 4 months. There were some that received medium as well as long-term. And then finally, some patients received radiation therapy alone without any addition of ADT. Here is a table that was actually provided by the paper for each of the individual clinical trials. You can see here that it is a diverse population. However, the representation is, I would say, not 100% representative of America or the prostate cancer population. African American patients were about 932, Asian patients were about 40, but a large majority were white. It was 4,503. Additionally, you really have to look at the accrual dates. These are trials that dated back all the way to 1992, where the radiation modality was very different than what it is now. So let's get started in regards to an overview of the multimodal AI architecture. This is going to be a summary slide really describing the overview of what this model actually did. And it was a combination of clinical data involving the age, the PSA, the Gleason score, as well as the T-stage. They combined that with digital pathology slides that they were able to obtain from each of these clinical trials. So the combination, the multimodal aspect of this is the combination of clinical data with pathology slides. The steps that they did to actually produce the prognostic score is they first digitized biopsy slides and they divided them into thousands of small patches. And then they used a neural network to learn meaningful histologic patterns. Once they had learned these patterns, the imaging features were combined with the actual clinical data that we kind of described just before, the 6 clinical variables. And once they had been combined, a fused machine learning model outputs a personalized prognostic risk score at 5 and 10 years for various different outcomes, including distant metastasis and overall survival. This is the 1, 2, 3 of the overall model. But one of the key takeaways of this model is that it attempts to really mimic how an oncologist thinks. It wants to combine what the pathologist sees as well as what the clinical oncologist may be presented as well, the medical oncologist. And one of the key questions that comes up in this paper is really, how did they train the model to read pathology slides? That is something that is not something that any traditional statistics can do. And so let's go on and answer that question. This is going to be a breakdown of specifically how did the model learn the histology, and how did it find these trends, and how do we know that it actually was finding things that were biologically true? So the first thing that they did is they combined all the tissue patches from each patient into one large image. Then each biopsy slide was really divided into very small image patches, around 256 pixels by 256 pixels. Then they used a self-supervised learning model that basically learned the histologic patterns without needing any type of pathologist annotation. So that's the 1, 2, 3 of it, but the step 3 doesn't necessarily explain too much. And so what I really want to kind of focus on in this slide is really what it did in those steps to identify those patterns and how it did it. So the model actually used something called self-supervised learning. It means that it trained itself how to read the unlabeled biopsy patches. It created 2 copies of the same patch and teaches the model that these should be similar, while areas that were taken from different parts of the tissue were told to be different. So it was able to separate areas that looked the same from those that looked different. It then used a convolutional neural network as the model's eyes. It started scanning these small patches and converting it into a 128-dimensional feature vector that captures the most important microscopic patterns. Think of a 128-dimensional feature vector as really just 128 characteristics that the actual model is picking up on. These feature vectors act as the numeric fingerprint of each patch. It really allows the model to naturally group similar histologic patterns and build useful representation for downstream prediction. The key problem with this type of model is that it's a black box model, and you don't necessarily know if the digital fingerprints that they're seeing are biologically significant. So in order to see what the machine is actually reading, what is it picking up, how is it clustering these different areas, they use something called a UMAP. So a UMAP is basically a dimension reduction model that is able to plot in 2 dimension the specific features that the model is picking up. So it applies UMAP to show a 2D representation of features, and in this map, it really identified 25 different clusters of morphologically similar patches. And those are the ones that you see over here. The machine identified these specific patches, 25 of them. And then in order to see what was actually going on in these actual slides, a pathologist reviewed the 20 nearest patches. And those clusters corresponded to real histology. They looked at these specific patches, and some of which corresponded to benign glands. Some of them were corresponded to necrosis. Some of them were artifact. But it was able to distinguish these specific areas. So the key takeaway from this UMAP clustering of patches in the pathology review is that the model had learned how to identify biologically significant prostate morphology, not just noise or random patterns. What they're seeing is something that is confirmed biologically by the pathologist. So that is how the machine was able to read the specific slides. But the next question becomes, how do they combine the clinical features with what the model is actually seeing in the actual histology slides themselves? And that's where it incorporates some of the clinical outcomes, not just the clinical characteristics of the patients. So the multimodal AI combines what it sees in the images with the PSA, Gleason score, and T-stage, and it also incorporates some of the clinical outcomes, such as the distant metastasis, and it uses machine learning, a machine learning prediction model, specifically called CatBoost. This is a gradient boosted tree model that basically uses many small decision trees to make a prediction. So in simple terms, each new tree fixes the mistakes of the previous one. So as it continues to make these decision trees, it improves its accuracy over time. An example of a thought process that might be similar to this, so how we might think of it in plain English, is that let's say you have a patient with a PSA of 12 and a Gleason score of 4+3 with cribiform pattern on the pathology slides. That results in an increased risk of metastasis. It gives it, let's say, a score. Then another decision tree adjusts the risk upwards or downwards depending on another feature. So let's say if they added on a feature such as, let's say the patient was 60, or let's say the patient was 90, that will then be factored into that decision tree that will refine it to really make the model more accurate. In the end, what is the output of this model? Well, it produces a personalized 5 and 10-year risk for distant metastasis, biochemical failure, as well as prostate cancer-specific mortality and overall survival. These are the specific the prognostic risks that they're going to be predicting from this model. So that's how they developed the model. But once they had the model developed, they wanted to see if it's actually accurate. They wanted to see if they ran this model on the 20% of population that they did not train it on, is it going to be what it intended to be? How was the model validated? And that's what we're going to talk about now. So the model was tested on 20% of the population who never saw the model during training. The model would basically gives a continuous risk score, and it was compared to the NCCN risk categories. The NCCN risk categories has 3 groups: low, intermediate, and high. So that's what it was used to compare against. The 2 prognostic models, the NCCN as well as the ArteraAI model, were compared using a time-dependent area under the curve, AUC. So what does this mean? So let's say you had 2 patients, both of which were classified as NCCN intermediate risk. Let's say that the ArteraAI prognostic model that they developed gives them patient A of a risk of 0.12 and patient B has a risk of 0.48. Let's say patient A develops no metastasis at year 5. Let's say patient B does have metastasis at year 5. The NCCN uses them as the same. So basically, the NCCN sees them as intermediate risk. It doesn't distinguish really between those two. So the risk of metastasis would be the same based on the 3-tier model. Again, this does not include unfavorable or favorable. The ArteraAI separates them correctly, for instance. In this specific example, we're saying that patient B does develop a metastasis at year 5. There's a typo there for patient B. I'll correct that later. But below, on the validation set, you can quite see that the model outperforms the NCCN categories basically in all of the categories. It is able to distinguish them, basically patients within the NCCN group, pretty significantly with an average of 9 to 15% AUC improvement. So just a quick refill or refresh on what AUC is. It's area underneath the curve. And basically, the AUC measures how well a prediction model separates patients who will have an event from those who will not. It plots sensitivity versus 1- specificity to show how well a model separates the patients who will versus who won't develop events. The events in mind in this specific paper are distant metastasis, biochemical failure, prostate cancer specific, mortality, and OS. It'll give you a score. And the score is going to be varying, meaning that it's 0.5 is no better than a 50-50 chance. You flip a coin and it's 50-50. The closer the AUC curve goes to 1, the better the model is. So an AUC of 1 is perfect discrimination, means that the model is completely distinguishing those who will have the event versus those who will not. So let's give an example of how you might interpret distant metastasis at 5 years with an AUC of 0.83. So the way that it will do it, that if you randomly pick one patient who develops metastasis and one who does not by 5 years, the model will have a higher risk score to the metastatic patient about 83% of the time. And if you look down in the validation set below, you can really look at the comparative test p-value, which is significant basically for all of the specific clinical outcomes. I will say biochemical failure at 10 years was borderline, but it was 0.004, which is quite good. However, that clinical outcome at 10 years biochemical failure is, I would say, a little bit less relevant than distant metastasis, which I think is one of the most important key outcomes. So now to conclude this paper, I want to talk about what it does do and what it does not do, in addition to the limitations and the strengths of the paper. So again, what does this paper do? It builds a multimodal AI prognostic model. It really has a good foundation of patients. It uses 5 separate phase 3 clinical trials. It provides an individualized 5 and 10-year risk predictions, and it shows strong discrimination that outperforms the NCCN by 9 to 15%. On top of that, one thing that it does do is that it does validate biologic plausibility via the UMAP and pathologist review. It also establishes a foundation for subsequent ArteraAI papers, 2 of which I mentioned earlier in this talk. It does not, and I'll repeat it, it does not provide a predictive model, meaning that it does not identify the patients who are going to benefit from ADT or not. It does not provide any new risk groups, and it is not validated in metastatic disease. There's no genomic or molecular comparison, and there's no prospective validation. This is all retrospective. Some of the strengths is, like I said before, it's a very large database. It is fully autonomous with the multimodal AI platform. Some of the limitations that we talked about before is that it is retrospective. Nothing is prospective. There's no prospective validation. It uses an older three-tier NCCN risk group that does not discriminate between unfavorable and favorable risk, and it is also purely prognostic. It does not predict treatment benefit. Some other limitations of this specific model is that it only uses the histology slides. It doesn't incorporate genomic or MRI into its considerations. Lastly, there's no defined clinical cut points or treatment recommendations. This just produces a continuous risk score. Further papers really refine on the specific cut points and treatment recommendations. So let's return to the case where we have the 67-year-old male who's got unfavorable intermediate risk prostate cancer and who has the following ArteraAI test. The ArteraAI, and this is basically what you're going to see when you order the test, provides a prognostic risk score. So the patient falls in this low risk category from their prognostic risk. It's in the 9th percentile of NCCN intermediate risk from 0 to 100. And they also say that it has an ST-ADT biomarker that is negative. So the paper that we just discussed really talks about prognostic risk. It does not mention anything about the ST-ADT biomarker. But what you can say is that this patient in the spectrum of intermediate risk has a lower ArteraAI score compared to the NCCN classification, and it better discriminates it than the NCCN in regards to those three categories. It does not do a better job of discriminating versus intermediate unfavorable versus favorable, but that was not included into this subhort. So you don't really know if it does or does not perform better than that specific separation. But what we still need to discuss is really the ST-ADT biomarker, and that involves a different paper. So I'm not going to go through the next paper thoroughly. I'm going to provide an overview of the paper and some of the similarities and differences to the first paper. But the predictive biomarker paper was published in 2023 in New England Journal of Medicine Evidence. It's labeled Digital Pathology-Based Prediction of Androgen Deprivation Therapy Benefit in Localized Prostate Cancer. The purpose of this study was to determine which patients benefit from short-term ADT when receiving radiation therapy. The population was trained on specifically intermediate risk prostate cancer. 72 of the patients were from 4 NRG trials, and that's how it was trained. It was validated on 28% of the population, specifically of RTOG 9408. Over 1,500 patients were randomized to RT versus RT plus ADT. That was the inclusion criteria. The methods overview, it used the same exact self-supervised learning pathology encoder that we talked about in the first paper. However, where it differs is that it does not use CAD-boost. Instead, it uses a multiple instance learning with attenuation. Basically, what it does is that it learns which pathology tiles predict treatment benefit. They really look to see which one of those categories of, in the UMAP, for instance, which one of the sections of the pathology that it's reading predicts a response to treatment. So that's what's called attention weights. Not all the pathology characteristics are treated equally, as in paper 1, which makes sense. We care about the part of the histology slide that actually is bad. So poorly differentiated characteristics are going to be more significant than those that are, for instance, well differentiated, for an example. On top of that, it uses a little bit of a different AI model. It uses something called a deep multimodal fusion network. It combines image embedding with clinical data and treatment data. If you remember from before, it did not include treatment data in the first paper. You're really only focusing on clinical data and images. This is basically a black box model, meaning that we don't exactly know which aspect it's weighting and which aspect is contributing to the worst prognosis or a positive or a negative value. So what does this actual paper output? What are you going to see and what is it supposed to do? It's supposed to develop a predictive score, a positive or a negative value. A model that is positive predicted benefit from ADT. A model that is negative predicts that there's not going to be any benefit from ADT. So in this paper, they published or they produced these two graphs. And what these graphs are is that they look at the risk of distant metastasis in patients who have a positive or a negative predictive biomarker. So for instance, if you have a positive ST-ADT, then you see that there's a clear separation of the curves for those who are at risk of developing metastatic disease. If it's positive, there's a clear benefit that the radiation therapy alone will result in a higher incidence of distant metastasis compared to if you add on the radiation therapy, if you add on hormone therapy to the radiation therapy, it's much lower. That's the blue curve on the bottom. It is statistically significant. And this is not as surprising because we know that unfavorable intermediate risk prostate cancer, a subgroup of the intermediate risk, will have a benefit for it. But what is interesting is that the negative predictive model, meaning that if it was negative, the risk of distant metastasis was essentially the same. There's not much separation of the curve, certainly nothing that is statistically significant. So what does this mean and how do you interpret this? It means that if you gave hormone therapy in addition to radiation therapy, it does not seem to make any type of difference in regards to distant metastasis. Now that is something that is different and that is something that is new and is potentially changing the clinical practice. Here we have two of the tables that they present. Again, they look at they look at 4 clinical outcomes: distant metastasis, prostate cancer specific mortality, metastasis-free survival, and overall survival. And then they separated those into positive and negative. Again, what you really want to look at is the positive and the negative for distant metastasis and prostate cancer specific mortality, where you have a clear separation that if it's negative, it really is equivocal if you do radiation or radiation plus ADT. Now, if it is positive, you can clearly see a benefit that these people need a combination of radiation and hormone therapy. And that's statistically significant. So from this data, I want to talk a little bit about the strengths and weaknesses of this, and then we'll return back to the case. So for the strengths, this is actually the very first validated predictive AI biomarker that I have seen, and specifically it's in localized prostate cancer. It's specifically an intermediate risk prostate cancer. It's built on a large multi-trial data set. There's validation specifically on one specific clinical trial that was not included into the training. There's clear treatment interactions, meaning that if a model is positive, if there's a positive biomarker, this shows a pretty significant ADT benefit. And if it is negative for specific populations or specific outcomes, such as distant metastasis, it finds something that shows that is basically equivocal, which means that you might not want to give hormone therapy to those patients. Some of the weaknesses in this paper is that it uses deep fusion network, which is a black box model. What that means is that you can't necessarily interpret it completely. You don't necessarily know exactly where the specific weights are placed on what specific variables and what is driving the outcome. We can't trace the true morphology pattern or the clinical variables that is driving the prediction. It also uses machine instance learning, which is attenuation weights. Again, it's not really described too well in this specific paper. I would have liked to have something similar to the UMAP in the first paper, where you have a pathologist really look over to what specifically is being weighted more heavily than others to see if that makes sense to the pathologist and to see if it makes biological sense. That's something that they did not at least publish in it. They may have done it afterwards. And it does not integrate any of the genomics or next generation imaging, such as PSMA or PET-CT or prostate MRI. Again, the last thing that I want to talk about, which is a little bit less significant for this one, is that it does not separate favorable versus unfavorable intermediate risk patients. It's just a positive or negative within the intermediate risk group themselves. So this is going to be a recording after the discussion itself, but I did want to summarize some of the highlights of the discussion with Dr. Dawson, who was present. And we're returning back to that case of that individual who has an unfavorable intermediate risk prostate cancer only because he has a grade group 3 on his pathology slides. So the consensus discussion with Dr. Dawson, as well as all the individuals in the meeting themselves, is that we would have had a discussion with the patient, and we likely would have offered to omit ADT with RT, despite him having unfavorable intermediate risk prostate cancer. Again, the NCCN guidelines recommends all patients who have unfavorable intermediate risk prostate cancer get ADT with radiation therapy. However, because of this negative ST-ADT biomarker, the ArteraAI, which is negative, and the data that we just reviewed, we did feel comfortable omitting ADT. Now, there's some important caveats with this. We did say that if there was any other high-risk clinical features present, such as the next genomic score or the decipher genomic score, which is actually being incorporated more frequently into some of the decisions in early disease, we would add ADT despite having a negative biomarker. The genomic information could potentially add another dimension that could predict for a high risk. It doesn't necessarily predict that they would respond to ADT like this ArteraAI score. The decipher score is purely prognostic. But regardless, if we see that they're high risk, we would have added ADT despite the negative biomarker. Some of the concerns that we had from some individuals or doctors in the meeting itself was that we really wanted to have some type of prospective validation for this type of study and this biomarker, especially moving forward in the high risk or very high risk with metastatic disease. There's so many variables, including imaging such as PSMA, and it would be very important to have some type of prospective validation, not just have everything retrospective, where you have some limitations like technologic limitations as well as classification with the NCCN limitations, as those did not change until more recently. But I do want to finish with this. The bottom line is this, that the ST-ADT biomarker does provide a clinically meaningful piece of information, and it can refine some of the decision making for patients in the clinic, specifically with unfavorable intermediate risk disease. And we thought that that was actually very significant, especially with certain populations where there might be a lot of mistrust that might develop for if you give someone hormone therapy that kills their libido or causes erectile dysfunction at an elderly age. I was thinking specifically even of the population within the VA, where if you can avoid giving them a treatment that won't really benefit them, but will cause significant side effects and quality of life discomfort, that is something that is very valuable. And that is something where artificial intelligence used in this type of way could be very clinically impactful. And with that, that's going to be the end of the discussion. I will send out the slides as well as the overview of all of the terminology and the AI 101 document. Thank you all.